Hi, everyone. Good evening,
Yeah,
everyone.
good evening, everyone.
Good to see everybody. Hi, Kirsten. Dr. Caroli.
Hi.
How are you?
Good. How you doing?
Good, thanks.
Hi, Amanda. Hi, everyone.
Oh, hi, Dr. Ramsey. There you are. I thought I saw you join. Hi, Dr. Pomerant. Hi, Dr.
Trying to
Dobson.
find the right lady. Okay, that's better.
Yeah, so everybody, we're gonna get started because we've got a packed schedule, and I know people are gonna join late. That happens. First of all, I did want to say happy National Internal Medicine Day to everybody. I'm psyched to be here with you guys celebrating it because it really is about you. I love working with you guys, and being here just shows how much you do for yourselves and your patients and your community, and that's awesome. That being said, I wanted to welcome everybody to the joint district event for Implicit Bias. We've got an awesome night. We've got Dr. Salifu here, a master of the college. He's going to be doing our presentation later on stereotypes and uncertainty in healthcare. And we've also got some great speakers, Dr. Mbako, and we've got a video from Dr. Chu as well. So we're going to start off with some stories and personal experiences with implicit bias. For those who don't know me, I am Amanda Allen. I am MACP staff. I am manager of communications and district relations. And before I turn it over to your official hosts, I just wanted to give you some technical tips. Everybody's on mute because we're in meeting format. I do welcome you to turn on your videos, get to know each other, be a little casual. It's less casual than a webinar. And then please stay on mute until the discussion, just so we reduce background noise. We've got a pretty packed schedule and exciting schedule, so I'm happy about that. During the discussion, if you could use the raise hand feature so I make sure we don't miss anybody, you can access that at the participants list, which if you hover over your Zoom screen, click on participants at the bottom, and when that opens, it should open on the right hand side, you'll see the raise hand blue button at the bottom. And then definitely use chat. If everybody wants to throw in chat where they're from, that's awesome. Where they're from in New York. I know the great thing about virtual is that we can get everybody from across the state. So use chat to talk to each other and keep the conversation going. And just one tip for the view, if you're only seeing me speaking, a little scary, sorry, you can change your view if you hover over the black Zoom screen in the upper right-hand corner. Speaker view will show who is speaking, and gallery view, you can see everybody who's joined. So if you want to switch that, you can. So I'm going to turn it over to your district presidents and your official hosts for the night, and they'll welcome you. Enjoy. Dr. Patel, you can go ahead and unmute and
Unmute.
There you go. You got it.
Hi, everyone. Thank you so much. My name is Anush. I'm an internist but mainly focused on, I'm a hematology oncologist here at beautiful Cooperstown, New York. I've been back for, I was trained here, went to Buffalo for a fellowship in Arizona, and then came back to Cooperstown. Been here for 9 years now, and I'm extremely honored to be part of this evening discussion. All of you for coming here. Welcome, everyone. I think this topic is near and dear to many of us, and especially this volatile time. So I just want to thank Amanda. I cannot say thank you to Amanda enough. We'll do it again. Dr. Salifu, Dr. Stracker, and Dr. Anandu, they did an incredible job. I'm just a face. They did all the work. So all of you, welcome to our exciting evening. This could be remembered for a long time. So I'll pass it on to Dr. Anandu.
Hi, thanks everyone for joining us tonight. As Amanda said, today is National Internal Medicine Day. It's actually also National Chocolate Day. Oh. And yesterday was National American Beer Day. So I'm going to celebrate all three of these with you tonight. Cheers. I first want to thank our outgoing president for Hudson Valley South, Dr. Donna Morrison, and the prior presidents, Dr. Moro Salifu. Thank you for being here tonight, Dr. Caroli, and to Dr. Sharon Krieger for their dedication and commitment to ACP and for their mentorship. Special thanks to the staff. As Dr. Patel said, Amanda has done so much for this. I thank everyone at our NYACP staff, and I thank all the people from the ACP staff in other chapters across the country and from national from joining us. I want to give some introductions and welcome to my fellow Hudson Valley ACP leaders. I think Dr. Pomerantz and Dr. Ramsey are here today. If you guys just want to say hi. And I want to welcome Hudson Valley South's new resident council board rep, Dr. Teresa Henson, and new counselor, Dr. Carrie Esketon. Dr. Teresa Henson is a pulmonary critical care fellow at Westchester Medical Center and has served on the NYACP volunteer and resident committee. If you want to just wave your hand, I'm going to get off I'm not sure if she's here yet. So Dr. Esketon is an assistant professor of medicine at Columbia University Medical Center. She's an associate program director of the Cardiology Fellowship, director of the Advanced Echocardiography Fellowship, and assistant director of cardiovascular ultrasound operations and the Vascular Medicine Laboratory. She has served as chair of the ACP Council of Student Members during medical school and now serves on the NYACP Education Committee in addition to her role as our region's counselor. And I think I did see her there. Yes, there she is. Hi. I'm honored tonight to introduce our first story presenter, Dr. Afole Mbako. Dr. Mbako completed his medical degree at the Perelman School of Medicine at the University of Pennsylvania and his internal medicine residency and chief residency at NYU Langone Health Bellevue Hospital. He's currently a third-year infectious disease fellow at Columbia University Medical Center. He's also a postdoctoral research fellow at the HIV Center for Clinical and Behavioral Studies. His research focuses on biobehavioral interventions and outcomes for racial, gender, and sexual minorities along the HIV care continuum. He's also broadly interested in how trauma, structural racism, and homophobia impact HIV-related outcomes. As a history and literature graduate from Harvard College, Dr. Mbako enjoys poetry, nonfiction writing, and narrative medicine, with essays published in JAMA, Annals of Internal Medicine, and kevinmd.com. Dr. Mbako, thank you for sharing your story with us tonight. We look forward to hearing from you.
Thank you so much. I mean, this is just such an honor to be with you guys tonight, and I'm looking forward to a great discussion. The title of my piece is Bonds in Every Color, and it can be found, it was recently published in the Annals of Internal Medicine. Each person entered the room with a hint of relief in their stride, their shoulders slightly more relaxed than before. They were mostly Black and brown physicians like me, at different points in their careers, interns, residents, fellows, and faculty. They came with stories of pain and resilience to share. It was the first meeting of its kind for the NYU Internal Medicine Residencies Organization Committed to Diversity, the idea originating from a group of Black female residents in our program. The conversation focused on experiences of discrimination against trainees by patients. This day was about supporting each other and sharing and listening to the challenges of being a trainee of color in medicine. Memories of these moments floated throughout the room. A senior resident spoke first, discussing the time her patient requested a doctor of a different race. The patient refused to look her in the eyes, as if she were not worthy of his gaze. She felt stripped of her humanity. A colleague spoke up for her at that moment, but the damage was done. To this day, she felt shame about her silence, as if she should have found the words to fight back. One of the attendings then recalled how years ago, an intoxicated patient with a life-threatening bleed called him a nigger during a rant in the intensive care unit. Critical illness seemed to bring ambiguity to the situation, with everyone hesitant to confront a patient shouting racist epithets who was on death's doorstep. The patient died hours later. Afterward, no group debriefing was held for the attending. He discussed the necessary tragic armor he had built around himself over the years because of experiences like these. The stories continued. The female intern whose patient commented on her body every morning, and the male senior resident whose patient complained about the heaviness of his accent. Hearing these stories in succession was shocking. As a chief resident, I felt compelled to share one of my stories. On a regular clinic day, My patient, a disheveled elderly man, limped into the room. His speech was pressured, and he was quite earnest to prove he was fine, despite the voices in his head that he had struggled with for years. As I tried to focus our conversation, he fixated on the tragedy flashing on morning news channels. A gunman had opened fire on LGBTQ patrons of color at Pulse nightclub in Orlando, Florida. At the time, it was the worst shooting in US history. Can you believe what happened? He asked repeatedly. I again tried to refocus him. Then he said, they deserved it. All those homosexuals and their sin. They gotta be punished at some point. I was floored by the blatant hatred in his statement. I left the room as my composure disintegrated into a million pieces. As part of the LGBTQ community, I identified with those who had lost their lives. I gathered myself before precepting with my attending. I thought about suppressing what just happened, filing it away with the collection of traumatic experiences and training I would never confront. However, something compelled me to speak about it. My attending listened patiently, validated my emotions, allowed me to decide how to handle the situation, and checked back in with me days later. She was the model ally. I finished that clinic visit, then rescheduled the patient with another provider. I found closure. It was challenging to listen to my peers, realizing that they often felt alone and that patients at times questioned their legitimacy because of a darker skin color, an immigrant accent, or a different hair texture. The patient-provider relationship is not immune to racism, misogyny, or homophobia, a salient truth that felt deeply unjust. Our time together as physicians of color laid bare the ubiquity of trauma in our profession. Medicine's implicit curriculum taught us to suppress our feelings, to seem strong in the face of adversity, to put the patient first, and to avoid being seen as difficult. Yet as we were vulnerable with each other, we drew strength from each other. We created our own curriculum. We laughed, held each other up, and affirmed our stories in tender, compassionate ways. The joys of community emerged from painful experiences. We made time and space for healing and connection. I found my allies in that conference room among familiar Black and brown faces. I also found an ally in my attending, a straight cisgender white woman who will never know what it means to be a person of color or part of the LGBTQ community, but did know what it meant to nurture an opportunity for reflection. It cannot solely be the responsibility of people of color to advocate for people of color. Our institutions are filled with male doctors who denounce misogyny, white doctors who despise racism, and straight doctors who deplore homophobia. The visibility of allies establishes a common purpose: to dismantle the legacy of silent suffering. We may not be able to stop discrimination in medicine completely, but we can better protect each other and transform painful experiences into meaningful bonds.
Thank you so much, Dr. Mbako. That was a really powerful story, and we truly appreciate you being here and sharing it. It was also interesting to hear how you incorporated other people's stories in that, other physicians, and how aware you are of what other physicians are facing as well. So thank you for sharing that.
My pleasure.
I am going to move into our next story, which is actually from the patient a physician giving it from the patient perspective. So we just heard Dr. Mbako talk about from the physician perspective, and Dr. Chu, who some of you might know from Twitter, she has 172,000 followers, so you might be familiar with her. She wasn't able to attend in person tonight, but she did record a story for us, which we're so grateful for. Just a little bit about her. She's a professor in the Department of Emergency Medicine at Oregon Health and Science University, and she was president of the Academy for Women in Academic Emergency Medicine. And on Twitter, she uses social media to influence her social media influence to talk about racism and sexism in healthcare. So I will share a link to, she posted on Twitter, so I will share that in chat as well, but I'm just gonna get her up here and get my screen shared and share the computer sound and let you guys hear her story. Sorry about that. Let me refresh.
I was taking care of a patient the other day who was very seriously injured, and I stepped out to talk to his family briefly and give them an update. For context, he was Black. I told them what was going on quickly and asked if they had any questions, and this is what they said. They told me he worked for a well-known company and that he was a respected role at that company, that he was on his way to work, that he is loved in the community, a good brother and son, that he was well dressed before the blood soaked his clothes. Nothing in recent memory has broken my heart as much as gradually realizing that a family of a shattered man, whose chief concern should have been, when can I see him? When does he get out of surgery? Do you know his meds and allergies? His mama gets to go in first. Had to worry that the racism inherent in the system and in people everywhere meant they had to spend their few moments with me putting him in a favorable light, shifting any possible implicit negative frame I had, like hoodlum or criminal, to get him the care he deserved. What is the goal of all our anti-racist pledges this summer? It's that this family can walk in with full confidence that their loved one is valued and cherished here, and that we will fight for his life with everything we have, no questions asked. I had 1 minute to the next trauma. I babbled stuff incoherently, and I'm pretty sure I got it wrong. The words of one random, disheveled Asian doctor don't change much against a lifetime of experience to the contrary. But I will carry this with me. We have so much work to do.
That was from Dr. Chu on Twitter. And like I said, she kindly recorded that for us. And we also have some, I believe at least one other post, one other story from another physician on Twitter. Dr. Anandu, do you have that, or is that Dr. Patel?
Yeah, so I got, so, thank you, Amanda. So, Dr. Mbako, I can, pretty amazing the way you narrated the story, and then the story and the story from Dr. Chu is just like so profound, and maybe me, it just makes me a bit uncomfortable. I think it just chills to my bones. So thank you for sharing that profound stories, and thank you, Dr. Chu, and thanks to Nandini. She has sent this Twitter from a famous astrophysicist, Dr. Tyson. I would like to read that to you, if I may. When my 88-year-old father suffered his first stroke, the hospital staff in Connecticut were quite indifferent to him, an old dying Black man. The next day, I hung bedside photos of him lecturing and getting an honorary doctorate. He was thereafter treated with a great respect. What's even sadder, perhaps, is that the life experience trained me to know that the photos would work in exactly the way they did. That last sentence just cuts so deep. Like, he knew since childhood that he has to do certain things to prove that he's just a normal person, and he should be treated with equal honor and with the equal care. And I think many of us may be oblivious of the fact, but this is not one or two or three incidents. I'm sure this is going on at a subconscious level all the time. So, and these are just a tip of an iceberg. This to tell us how this thing is engraved in our community, how it is engraved this is a way of life for many people. And because of time, I'll pass to Dr. Anandu, and she has many more things to say, followed by Dr. Salifu's talk. So I'll give a stage to Dr. Anandu. Thank you.
Yeah, nothing to say yet. I'd rather get to Dr. Salifu's talk, and we can have discussion later.
Great, thank you both. Thank you everybody who came and shared stories. Dr. Salifu, I've had the pleasure of working with him on previous presentations, and I was supposed to have a 10-minute conversation with him once that turned into an hour because I've learned so much from him. So I'm really excited to welcome Dr. Salifu. Just a little bit about him. He is a tenured professor of medicine and chairman of the Department of Medicine at SUNY Downstate Health Sciences University in Brooklyn. He is also the Edwin C. and Ann K. Weisskopf Endowed Chair in Nephrology and Transplantation. Board certified in internal medicine and nephrology, Dr. Salifu is known for his outstanding research and clinical and administrative skills. He is a productive investigator whose research includes vascular biology, chronic kidney disease progression, and kidney transplant outcomes. He is a recipient of numerous grants, including being the principal investigator of the multi-million-dollar award from the National Institutes of Health to advance the work of the Brooklyn Health Disparities Center, where he promotes health disparities research in all fields and fosters collaborations between stakeholders that will result in research addressing health disparities. He has published extensively in peer-reviewed journals nationally and internationally. A master of the American College of Physicians, he is also a member and journal reviewer for nephrology and transplant societies and has served on many local and national professional committees. I welcome Dr. Salifu.
Wow. First of all, I'd like to thank all of you, especially the two presidents, Dr. Patel and Dr. Nandu, and your governor, Dr. Pomerantz. I see a number of known faces from your district, so that is very good. I also like to thank Amanda for the work done to bring this to fruition. It's actually a very, very good program, given the stories that have already been told, very moving stories, and they just follow very nicely with the talk that I'm about to give very nicely and smoothly. I also want to thank Pamela Straker, who is in the audience. She's the Director of Operations for the Brooklyn Health Disparities Center, which is down here. The Brooklyn Health Disparities Center is dedicated to eliminating health disparities in Brooklyn. So we do a lot of work in the community, and it's well funded through the NIH programs. So today I'm going to be addressing the issue of implicit bias, stereotypes, and uncertainty in healthcare. This topic is not a racial justice or social justice talk. I'm angling this talk around healthcare and what we can do to improve the quality of care. It is very complicated. Like Amanda said, we met about a month ago with Dr. Nandu and then Dr. Patel. We thought we were going to hang out for 15 minutes trying to plan this meeting, and we ended up talking about 1 hour just trying to decipher what it actually means. It's just not obvious what it means, but if we continue to open this discussion and dialogue, more and more people begin to become attracted to what it actually means, and then begin to improve the quality of care for every patient, and that is the goal. So it's not a very long talk because I wanted to spend time on the slides to be able to explain them and to be able to take questions at the end. So there are 4 segments basically. The first segment deals with the groups that are at risk. So it's not just one group, it's just multiple groups that are actually at risk. And then we will talk about the clinical encounters that actually give examples of this situation. And then we will then piggyback on the historical perspectives that drives this phenomenon of implicit bias and stereotypes. And then we'll summarize, and then we'll take some questions. So let's move to section 1. So this deals with every single segment of the population, right? So the vulnerable populations described by the NIH and other government agencies by race, age, race, ethnicity, gender, and gender orientation. This we don't talk a lot about, but somebody brought it up. Dr. Mbaku actually mentioned this a little bit, and that is really, really very important, and gender identity. Then of nationality, political orientation, language, religion, socioeconomic status, and history of discrimination or marginalization. That is, the example is going to be Native Americans here or African Americans. So when we talk about vulnerable populations, it's all this stuff here. Some of these areas we have very good examples, and some we sort of know is there, but we cannot give like real concrete data. The data on African Americans is so strong. That is why when we're talking about these issues, we want to use the African American data, because that is really, really nicely recorded with laws and policies that have been passed around it to be able to have an informed discussion. So a lot of my discussions today will be around Black African American. So why is this topic important? It's important because of these two things. We want to be able to measure the quality of healthcare between the non-minority population and the minority population. Assuming that there was equal quality of care, then we don't have to do anything at all. Everything's fine. We have a nice day and we move on, right? But that's not what is happening. There is actually a difference in quality of healthcare. And this difference can actually be measured. If you go to literature, and I'll show you some of the examples, it can actually be measured in cardiovascular care, in renal care, in all types of care, stroke outcomes, and emergency room visits for pain management and all that stuff. You can actually quantitatively measure the difference. So there's a difference where non-minority populations have a higher quality of care compared to minority populations. So there's a difference. And this difference is what we classify as, is it because there is, patient preferences? If the patient, wants something and the doctor is recommending something else and the patient refuses, hey, it's not the problem of the doctor, right? Or the health system. It's just that the patient prefers to do something different. Or is it because of the complex healthcare system that we work in that is causing the differences, right? And in the United States and maybe in other parts of the world, the healthcare systems are really, really very complex, such that if you're not up to speed, you cannot actually follow everything in the healthcare system. Just signing up for insurance plans alone is a headache for a lot of people. And they may have the resource to be able to do that, but they don't even know how to start to engage the healthcare system. Go to this website and put all this information, and you get your card in the mail and all that stuff. It's just complex. You want to get the CAT scan done, and then the doctor says, "Oh, we have to get prior authorization." And then it becomes a whole huge problem for everybody. Or the patient has to get 10 visits for a year, and then if you want the 11th visit, you can't get it. So there are just too many complex healthcare systems issues that also account for the difference in the quality of care. Then the last piece is discrimination. That's basically bias, stereotype, and uncertainty, and that is what I'm going to talk about today. So if you look at what the Institute of Medicine in 2003 classified as unequal access here, it's actually all these areas of the difference that is accounting for the quality in healthcare. They're actually sort of proportional, right? So the refusal of treatment probably accounts for maybe 1/3. The ecology of healthcare systems also probably accounts for about 1/3. And then the discrimination issues probably accounts for about the same number, right? But when you talk about disparity, the disparity should not be because somebody prefers to do something. So the disparity is actually, how people actually access the system and the discrimination issues. That is where the disparity always comes from, right? So when we say healthcare disparity, you actually mean these two areas. And I'm going to be coming back and to this slide because this slide just makes the point over and over again, right? The essence of these conversations is to narrow these differences, narrow the gap. If we could understand what the ecology of the healthcare system's factors are in preventing some from accessing the system, we can find solutions to those problems. If we understood what these bias, stereotype, and uncertainty issues are, we could address them and narrow the difference so that there is no differences, or at least there's no statistically significant differences in the quality of care we provide between all the ethnic groups in the United States, okay? So the last box, which is the discrimination box, has a historic context, which we will go into that. But in the context of our discussion today, it is used in the context of the differences in the quality of care, right? So what is uncertainty? Uncertainty simply means when you encountered a patient as a physician, the patient is not of your own ethnic background or socioeconomic status or whatever the difference is, you will get as much information as possible from that patient. But there's always a point where you can go further in terms of getting information, and you have to now use your clinical judgment to figure out what is the best thing for this patient. And the best judgment always defaults to what you think as a physician is best for this patient. Now, Those uncertainties are based usually on priors. We call them priors. That is, evidence shows that, African Americans are more likely, for instance, to be, let's say, 16 times as hypertensive as white people. Let's say diabetics are maybe, African Americans are 4 times more likely to be diabetic than, Caucasian population. Or that dialysis is more prevalent in African Americans than the general population. So when we actually don't have all the information to make a decision, we default onto the priors and some of the things that's written in the literature that helps us to make those decisions. But those decisions may not necessarily be the right decision for that particular patient. So those are classified under uncertainty, but they do treat the patient in some way. Stereotypes is a little bit different. Stereotype is how we actually label, the word label, how we actually label things, okay, as good or bad, in simple terms. So something is good or bad, it's rich or poor, it is nice or not nice, it is compliant, not compliant, educated, not educated, criminal, not criminal. It is how we actually perceive another group and label that group. That is stereotype. Now, it could be explicit if you say it, right? And nobody really does that a lot, but some people do. Or it could be implicit, that you actually have it as a result of your being, your growing in society and where you live and who you interact with and how you are made, how you are formed as a human being before you get to medical school. And even your relationships in medical school and what you read and all that stuff all the way to graduation. What forms you as a person that allows you to label things as good or bad, red or brown, whatever, they are called the stereotypes. You may not necessarily know that you are labeling things, but your growing is what allows you to label things. And every human being in this planet label things. Every human being, whether you're in Australia, you are in, you are in Brazil, or you're in Europe or United States, there is stereotyping based on ethnic groups, racial groups. Everybody labels the other person, but it's there. It doesn't bother you, it doesn't bother anybody, but those labels are there. But in the summary, the labels are actually translated into good or bad. Whereas whatever is described as, all the adjectives for, what is bad, it falls under bad, and what the adjectives labeled under good all fall under good. So those are stereotypes, the labeling. The biases is actually the actionable portions of the labeling, right? So what you actually do when you have a lot of stereotypes in your head, right? So what actually comes out as a result of the stereotypes is the bias. So you will tend to take an action that you actually don't know that you're taking that action, or you actually believe that that action is the right action for that particular patient. Again, this happens all over the world. There is no, geographic area, region, country, nation, whatever, continent that doesn't have these biases within its population. So the bias is just part of being a human being. Now, the way it is expressed can actually hurt other people, but it can be implicit. In other words, you don't know that it's actually happening. You are doing it with all the best intentions, right? But it's still hurting the people without knowing it. And it's hurting the people because of these stereotypes. And those stereotypes are ingrained in the way the mindset operates in reaching a conclusion, right? So then it translates into biases of doing things. But it's most common when medical decisions are being made under pressure with limited information. So biases are more common in the emergency room setting, where you have to make a decision quickly and then you have to go to the next patient, and then you have limited information, right? So you have to use your best judgment and just move on. But the response, what you actually get is what? Mistrust and refusal, because patients also over time learn that, oh, this happened. Oh, well, maybe the doctor is not giving me all the information, and they may refuse treatment, or they may say, okay, I'm going to sign out. And then the doctor may not know, but you're sick and you're here, I'm trying to treat you. Why are you trying to sign out? It is because the patient has to respond, because they also know about the biases, or when they feel it or when they suspect it, they are going to respond. And when they respond, it's going to be in the form of a mistrust or refusal of treatment. Okay. But in this context, again, we're focused on the quality of care. These will definitely affect the quality of care, whether the patient is refusing or we are doing it unconsciously, providing care that we think is the best care, but it's actually not translated to the best care. It all leads to low quality care. And these are the examples clinically. Okay, clinically, you have literature, a lot of literature on any kind of procedure, just name it, you know, bypass surgery, amputations, whatever you name it, there is always a disparity. Cancer treatment, cardiovascular disease is the most talked about, HIV, AIDS, diabetes, mental illness, routine treatment for common health problems, even pain relief. Patients come into the emergency room for pain relief. There is even a difference in how we actually provide pain between ethnic groups. Okay, whereas the African Americans, as an example, would not get enough pain relief compared to Caucasian population present to the emergency room. So these are not things that you know, postulated. These are hardcore research findings, and they're all over the internet. And the most recent one, which came in August of this year, and CNN got this story and made a lot of noise around it in the evening, was that babies born by white doctors were more likely to die than born by black doctors. This actually shocked the entire country. But why is it so? Is it that the white doctors were not, you know, delivering the babies properly? Of course, no. They didn't like the white mothers? Of course, no. I mean, 5 to maybe at the most 10% of the OB, that is obstetricians in the country, are white because of just the population differences. Only 10%, right? So most of the patients are actually going to white doctors. So why would they not like them? The relationships are solid. There's no problem with interactions leading all the way to the delivery, but the outcomes are still poor. So it means that there is something that we have to decipher, right? We have to decipher around that. So these are solid research, you know, things that have happened, and that is the reason for these conversations. Because one of the areas that we can explain these differences is how we actually stereotype and how we actually come up with biases that we ourselves have absolutely no knowledge of what we are thinking, because we are trying to do the best for the patient. We just feel that it just happens that the bias flows with the decision-making process, and then it happens to affect the outcomes. So this is an example, cardiovascular literature, of a very nice study, total of 720 physicians at 2 national meetings. So they got these actors to, and they videotaped these actors with specific complaints about chest pain. So you have, you know, middle-aged, you know, woman and the man, African-American, and then elderly woman and man, African-American. Then the same thing for white, you know, this is middle-aged and this is all elderly, white and white. Right. So they had a very nice representation of black and white, and then they gave an exact same script for chest pain. And then they, you know, took the history on the video, and then they played the video to these 720 physicians in this meeting to see whether they will recommend further procedures, cardiac cath and intervention or not. Right. And then when they finished the analysis of the 720 physicians watching this video, this was what the conclusion was. Blacks and women in general, whether white or black, but blacks in general were less likely to be referred for further workup. In other words, if you had a chest pain based on that video, right, and then this is the guy who was complaining of it, this guy or any of the women, you are less likely to actually proceed to cardiac catheterization. And the black women particularly were less likely to be referred. Okay, so why? Because it's videotaped, it's exact same script, and these are professional video people. They've done exact same recording, and 720 doctors are viewing this recording, and they come up with different conclusions. Okay. So this is implicit bias in action. The second example is the black newborns born likely to die when looked after by white doctors. It's another good example, and this is a very nice paper. This is the reference here. You can actually read about it, but it's also another implicit bias example in action. So now let's examine the historical context and see how the implicit bias evolved. Because what happens is that the implicit bias itself is evolving because of stereotyping. And so these examples are around that, how stereotyping evolved, although there is the context to the racism stuff and all that stuff, but that's not the essence of this conversation. It's to give you the historical context of the stereotypes. Okay, so right after slavery, the Jim Crow laws mandated segregation in most facilities by the state and local laws, which meant that black people couldn't go to where white people got healthcare. We were just completely separate. And then this was challenged by Ferguson, Plessy and Ferguson in 1898 at the U.S. Supreme Court. And they said, no, no, you can have it as long as the quality is okay in both settings. So basically it's the same thing, as long as they're equal. The first crack, right, at this segregation thing was in 1946 called the Hill-Burton Act, passed by Congress. This now allowed public funding for hospitals, but prohibited discrimination, but allowed for separate but equal facilities, which meant that you could have a hospital, have the West Wing and then the East Wing. So it's the same facility as long as the West and the East are the same, right? So that was the Hill-Burton Act. And then that was now abolished in the 1964 Civil Rights Act. That said, no, 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 you can't do that. You know, if the West Wing and then the East Wing have to have everybody, right? If you want to receive the federal funding. But this was now operationalized in 1965 when Medicare and Medicaid came out. They said, okay, if you really want to get this money, you have to follow these rules in order to get your check. Otherwise, you're not going to get a check. And that was when the Mixon Act really started. So in healthcare, you see that the segregation started in the beginning and then slowly, you know, got away. So you can argue that there was government action here, which was very, very negative for years and years, maybe close to 100 years. But later policies by the same government became more and more positive. So they're negative, but later policies became more and more positive, such that in 2010, we had health insurance coverage for a lot of people, close to 20 million people, signed into law by President Barack Obama. The other phenomenon that caused a problem in segregation was a phenomenon called redlining. This was a complex issue, but the summary is that you know, the big banks actually demarcated the land in cities and then created zones of redness and green and all that stuff, yellow, whereas red means that you know, you had no chance of getting these things. You had no chance of getting mortgages, student loans, credit cards, and insurances. So these were permanently neighborhoods that were made poor from the 1930s. And then the government actually had these loan programs that actually funded the green areas and then the yellow areas. So you see that neighborhoods were growing from government funding and neighborhoods were suffering because of lack of government funding or deliberate lack of government funding. And this neighborhood persists till today. If you are in the, you know, big metropolitan areas like Chicago, New York, and all that, you see these red zones, and they are still there. And it's very hard to change these neighborhoods because of the history. The policy was made illegal in 1970, but of course the negative effects continue to persist. Then there's the mistrust issues in the healthcare system. From research, this is the era of anesthesia. Our famous gynecologist is represented here, Dr. Marion Sims. He was doing rectovaginal fistula surgery in African Americans because he felt they were tough. And then, you know, they didn't need anesthesia, right? That was now, you know, known to be true. And then actually he was really revered. He's one of the big guys in gynecology, and his statue was in Central Park. And that was removed in 2018. They realized that that was not the case. And then there's the Tuskegee syphilis study that everybody knows about, experimenting on Black people for 40 years just to understand the natural history of syphilis was not, you know, a good thing, and became public in the 1970s and then created a huge mistrust in the healthcare system. And then there is the Henrietta Lacks story, where she went to Johns Hopkins Hospital for cervical cancer treatment, and then they did the biopsy and realized that her cells became immortal. The cells weren't dying. So wow, these cells, we can use them for experiments, we can use them to do studies and then drug discovery, and boom, it became huge in the entire NIH infrastructure without the knowledge of the family. And it became big news, and then the people, you know, feel, you know, left out, or if people feel that you know, you're experimenting on them without their permission. So these are issues of mistrust in the healthcare system that affected mostly in the 1980s and 90s and maybe the early 2000s. I think it's improving a little bit, but there are systemic issues that are still in the system. So these historical contexts meant that there was delayed wealth accumulation. So you're going to see poor people. That's where the stereotyping comes from. That's my point. You're going to see, oh, he doesn't have insurance, but you don't understand why he doesn't have insurance. He doesn't have a home. The guy is in the house and he has to go to shelter. What is that? Because you never saw it. And you didn't go back to read to know what happened. So the delayed wealth accumulation created a lot of the problems, social determinants, that are now, you know, somebody's uneducated, not having a house, you know, maybe criminal, maybe doesn't have all the health literacy to be able to understand what you're talking about. That is coming from that, right? The persistent segregated neighborhoods and poor neighborhoods adds more to that problem. Then you have the bias and stereotype that says, oh, maybe he's experimenting on me. That's now mistrust. Okay, I don't have the money, but the guy is saying something else that may or may not help me, even though it will help you. Then it becomes a problem for the person to follow your instructions. So that is what the historical context created. And of course, there's now psychosocial trauma in these communities, poor social determinants of health, and high risk of comorbidities. And that is what we're seeing right now. So the stereotypes and the biases are, this is the summary of what it means. So for the doctors, what do we do? So we can't keep talking and complaining, right? We have to figure out a way to connect and improve the quality of care. Our job is to improve the quality of care, not the racism and all. Of course, that is important, but our job is to improve the quality of care. So we are trying to figure out where is that problem coming from so that we can close up the gap from the first slide, the quality of care gap. So implicit bias training is very important. I know that you also, the president's executive order, they're saying that in the federal government system, they will no longer be doing implicit bias training and diversity training for whatever reasons they have. So I always, I actually told my partner, Pamela Stricker, the director of operations for the Brooklyn Health Disparity Center, I said, okay, that's what they did, that's fine. But let's ask one more question. The question is COVID real or not real? And would you wear a mask so that you don't get infected or don't spread infection to another person? It's the same question. That is it's either real or fiction. COVID is real, so you have to wear a mask, right? These historical perspective that created this monster here that I'm talking about is also real. It's not like people are making this thing up. This historical context, we're not going to go back to the historical context, but we're talking about the implications. This is not made up. This is actually true. The wealth gap is just amazing, right? The wealth gap, as an example, the 60% of the of African Americans' wealth, right? No, sorry, 60% of salaries, right, is comparable to what a typical white person would make in this country. So it's not a lot of gap. 60% versus 100%. It's closing slowly. So for the same person, 60% and 100%. Okay, but if you talk about the wealth itself, it's 5%. African Americans have 5% of the wealth of the Caucasian population. So these are real stories, right? And that is where the problem is. So we can say, oh, we will not be doing implicit bias training, but we're hurting ourselves. It's like saying, oh, we have COVID, we're not going to wear masks. Of course, then you're going to get more COVID. It's that simple, and that's what's happening. We said we're not going to wear masks, and we had more COVID. So this is exact same thing. So I think we should let the politics get out of our way so that we can find ways to close the quality gap, and we should keep focused on the quality gap so that we can close it. Patient education empowerment is very important. I would, this is actually something that some people do. If you're in an office-based setting, you have to find, material that people can understand at the level of what? The 5th grade. If you can find education material that people can understand at the level of 5th grade, you are really doing very good. But a lot of time when you go to physician offices, you have complex information nobody can understand, even including Caucasian population, right? We have to simplify the information. We have to, approach everyone based on evidence-based guidelines, not the fact that somebody, oh, by the way, women are less likely to have costochondritis and chest, wall pain. It's not cardiac. Okay, you go home and then take Tylenol or take naproxen, and then if it doesn't get better, you come back. That approach should just be abandoned completely. If you're going to treat a man because of chest pain let's do the cardiac enzymes, EKG, and all that stuff, then the next person who comes, it doesn't matter whether it's a man, woman, or black, white, you should do exactly the same thing. Then you realize, you see that you've abolished your implicit bias. Just follow the guidelines and treat the patients, okay? And then support the use of interpretation services, because sometimes there are people who just don't speak English, and then you have to support them. And then you increase the proportion of underrepresented minorities among health professionals. This is very important, especially for physicians. Right now, the number of doctors, African-American doctors in the United States is only 7%, right? It's not possible to solve this problem with 7%. It's not possible. So that is one of the areas that we can improve and make sure we have more conversation around the area. And for the patients, patients have to be made aware of the potential for implicit bias so that they can actually, figure out what is good for them and whether they can detect it and actually correct, the doctor, and then make sure that they're getting what they're supposed to get. Make improvements in the following, which is health literacy. We have to figure out a way to get patients to actually understand what we tell them, okay? Or encourage them to read about what we tell them so that they can come back the next time with a lot more information and a lot more understanding than what we told them the first time. We have to provide them enough health information to be able to understand what we're telling them, and then provide enough health services so that the services are nicely and tightly connected, so that patients are not like, bouncing back and forth. You come to this hospital, you get one piece of service, then you go to another hospital, get another piece of service. Then you get tired, bogged down in this complex healthcare system, you can't just move, okay? And then the last piece is health advocacy and then second opinion. If you are sensing that the patient is not comfortable, right? You're trying to discuss a medical intervention or pathway for recovery, and you sense that the patient is not comfortable. And I do that all the time in clinic. I just ask them, and it happens to me too, even though I'm taking care of mostly African-American patients. I can see it in their face because I'm a doctor. So the doctor, when they see a doctor, it's not different between black and white. They just see a doctor. I can see the discomfort, and I just offer them, you need a second opinion. And I would gladly arrange a second opinion for you, but please don't get lost. You go, you get your second opinion, bring the second opinion back. It will help me take care of you. And the moment I say that, you see that they take a deep breath and they just relax. They feel very, very comfortable now. They know that, you have their welfare at heart. And now you can tell them more things that would actually help them recover. So to summarize, I would want to say that we, the providers, should be made aware of this the disparity issues in healthcare and the fact that, we are doing our best and they still exist, right? We're doing our best. None of us in this conversation will say that they're not doing their best. And if you go back and ask those, OB, the obstetricians who gave birth to those babies, they'll say, wow, what is that? I did my best. I mean, we exchanged even these cookies and all that stuff. And this baby was so good to come out and breathing and really nice and good, looking good. They will not even know because there was no intention to do any bad. That is the beauty of implicit bias or the worst forms of implicit bias. In other words, we don't know. We just do what we're supposed to do, but it ends up in some care that is unexpected. And that is why we have to know about it, so that we're more conscious and then we can, improve the quality of care for these patients. And of course, all healthcare providers and patients can benefit from this cross-cultural education whenever we have the chance to do so. So I would like to stop here, thank the district again for the invitation.